We are live.
Good evening, everyone. Welcome to this series of AIOS webinars. And today we are going to discuss how to deal with a patient walking in with abnormal pupil, how to triage and manage. And today we have a wonderful group of speakers, and the chairpersons are Professor Samar Basak and Professor Omapati Tirunjana, who is a senior neurologist from National Eye Center, Neurosciences Hospital and Institution, Singapore. And along with me, the moderators are myself, Dr. Santosh Janawar, who needs no introduction, and Professor Manoj Mathur. And we have a wonderful group of expert panelists from different, senior institutions and wonderful speakers and experienced neuro-ophthalmologist, Dr. Mahesh Kumar, Head Aravind Eye Hospital Neuro-Ophthalmology Services, Dr. Ramesh Kekunya from LVPI Hyderabad, and my friend Dr. Rashmin Gandhi from Center for Sight Hyderabad. And these are the group of speakers whom we are going to deal today with, where all have come with exciting neuro-ophthalmic cases, particularly with abnormal pupils and how they faced clinical challenges in decoding the cause. Dr. France Mary Cruz, she's from Philippines, and Dr. Padmalakshmi from Shankar Nethralaya, Dr. Kumudini Sharma from Lucknow, and Dr. Luciano from Brazil, and Dr. Mangai, who has her roots in India from USA, and she belongs to University of Kentucky. So this is how we are going to go ahead. And unfortunately, I think Dr. Santosh is traveling, so he'll be not able to do that. And if Dr. Samar Basak is around, I would request him to give you opening remarks. Is Dr. Basak around? And then we can move on to the keynote lecture from Dr. Omapati. Okay, I think we will move on to Professor Omapati for his first presentation, keynote lecture on abnormal pupil. Over to you, Dr. Uma.
Thank you very much, madam. It's an honor indeed, and to start the session. I guess in view of the recent performance of the Indian cricket team, especially Rohit Sharma, it's not really good to be an opening batsman, right? I guess, but I hope I won't do a Rohit Sharma today. So the main disclosure along the same lines that I need to say is that I'm not ophthalmologist. So I'm a neurologist. So please forgive me for some of my naivety as well as the ophthalmological issues are concerned. Okay, so with that, I'm going to start with a patient. This is a patient, young girl that I saw some time ago. Some of you may have met her before because I presented her before. She's a young girl that I saw a few years ago in Peshawar. As you remember, Peshawar, as you know, Peshawar is a city in the northern part of Pakistan, bordering Afghanistan. And this girl is actually Afghani, Pashto from Afghani, who comes to the main hospital in Peshawar for treatment. And she came to us in the neuromuscular clinic with this complaint that she actually came from pediatrics. And pediatrics gave us a very short letter just to say that she's a young girl with no past medical history, 4 years of age. And she was admitted a few weeks ago to pediatrics for a severe sore throat that was treated with antibiotics with good response. At that time, she had some dysarthria and dysphagia. Then there was no other details given about that. She went home and then subsequently developed weakness of her limbs, and but there was no sensory complaint. So when we started examining her, we found that there was some limitation of eye movements. There was very mild ptosis, questionable fatigability, bilateral facial weakness, some nasal dysphonia from palatal weakness, mild proximal weakness in the limbs as well as in the neck, and the reflexes were reduced. So there I was working obviously with a translator who was a Pakistani resident. So I turned to him and, just like what Andrew always says, I told him, that when something looks like a duck, walks like a duck, quacks like a duck, flies like a duck, it must be a duck, right? So this is a patient who comes with an antecedent infection, after which she develops ascending weakness of her limbs with loss of reflexes, and she develops cranial neuropathy. So all over the world, the most common cause for such a condition would be Guillain-Barré syndrome. So I said, this must be Guillain-Barré syndrome. But this Pakistani resident, being a South Asian doctor of very polite upbringing, didn't want to contradict me openly. So he started whispering to me very quietly by pulling on my sleeve and said, "Doctor, doctor." And I said, "What? You said this could be a duck, but could this be a goose?" Then I said, "What do you mean?" Because he didn't look like a person who will joke about a duck and a goose. So I said, "What do you mean by a goose?" So he said, "Oh, you said it looks like a duck, walks like a duck, but we have a problem here because in the Afghan tribes, the women, the mothers of the children are expected to remember the vaccination protocol. There's no system of healthcare. So a lot of times vaccination for measles and infections like diphtheria are not sorted. So we often see diphtheric infections. So he said, could this be a goose? That is, could this be diphtheric neuropathy? So as if to prove the point, at the same time, we saw 5 or 6 patients with actually diphtheria, just to show you, if those of you who have not seen patients with diphtheria. So this is a man. You can see he's got a big, you can see the membrane there. And this is another girl. So at the same time, there are 6 patients in the ward with acute diphtheria. So all these are patients for some reason or another not vaccinated. So diphtheria, measles were very common. But of course, my heart sank. I'm familiar with diphtheria, but diphtheric neuropathy is something that I've never seen in my life. But fortunately, I remembered, so one of the physical findings that you can get in diphtheric neuropathy is what we refer to as the inverse Agar-Robertson pupil. That means the opposite of an Agar-Robertson pupil. As you all remember, Agar-Robertson pupil is a pupil that reacts poorly to light, but very well to convergence and near reflex, and it accommodates very well so that the pupil constricts very well to a near response. But an inverse Agar-Robertson pupil just does the opposite. It reacts very well to light, but there's hardly any constriction to convergence. So if you look carefully at this girl, you notice that to light, there's fairly good response. And in the later part of the video, when I'm trying to get her to converge, okay, through a translator, okay, and she's trying to converge on an object that was just behind the camera, just in front of the camera, and you can see there's hardly any pupillary changes. So this was a physical finding in the pupil that was very useful in this context to diagnose diphtheric neuropathy. And then a few months later, when in a different context, this was in Africa, we saw this young girl with recently diagnosed HIV who came to us again with what sounded like Guillain-Barré syndrome, ascending weakness after an antecedent throat infection. But what was interesting about the throat infection is that when you ask this girl, she will tell you, "Doctor, the throat infection was so bad that I couldn't swallow." Then I said, "Oh, it must have been because it's painful." Then she said, "No, doctor, it wasn't painful. It was so bad that, nothing went in. So they had to put in a nasogastric tube and my voice was coming through my nose." So essentially she had bulbar palsy. And not only that, she had also numbness around the lips. So local toxic effects of the diphtheria. And then she was given antibiotics. Of course, this was a community hospital with, again, no microbiological capacity to diagnose diphtheria, just like in Peshawar. But they treated her empirically with penicillin, and she got better. When, very interestingly, she went home, started work as a secretary, and about 2 to 3 weeks later, she came in with weakness and numbness. Now, this biphasic sort of a neurological deficit around the infection, the bulbar infection, that disappears, and then a few weeks later coming in with ascending weakness, is very unusual in Guillain-Barré syndrome, but typical for diphtheric neuropathy. But very interestingly, her pupils were not Agar-Robertson or inverse Agar-Robertson. In fact, if you look carefully, you realize that she actually has a tonic Holmes AD pupil. Big pupil that reacts very poorly to light, and then under a microscope of a slit lamp, you can see the sectoral dyskinetic movements of various parts of the iris. Okay, typical of a Holmes AD pupil. Okay, this is another patient that I saw in Africa. This man is a young man, highly suspicious for HIV because of his background, although not diagnosed yet, came to us for an acute myelopathy. But what was interesting was his pupillary findings. Okay, his small pupils were not reactive at all to light. small pupils, not reactive at all to light. But in the next video, you can see quite dramatically that when I give him a convergence, his pupil constricts. So this is a small pupil that reacts better to accommodation than to light. This is Agar-Robertson pupil, and we were very suspicious in the context of HIV that he's got a syphilitic eye. Okay. Then very soon after all these patients, I happened to be actually in the COVID wards, and my partner was actually an ophthalmologist. And it so happens that there was a patient who was admitted to the hospital because he had was diagnosed positive with COVID by COVID swab, and he was a foreign worker, and he was given quarantine document to read. And although he's literate, he suddenly told the quarantine officer that he couldn't read. So everyone thought he was hysterical. So they initially wanted to call the psychiatrist, but it so happened that we were in the ward. So they asked us to have a look. And very interestingly, we realized that he had no near response. There was no accommodative response at all, although he was responding very well to light. And we managed to publish this. So after this, we sent out the notice, and in the same few months of the first outbreak of COVID, we found one patient with what looked like an inverse Agar-Robertson pupil. We found a patient with classic Agar-Robertson pupil. And the third patient was this patient who had some systemic signs of autonomic dysfunction. And in his pupils, he had a classic tonic Holmes AD pupil. Large pupils that did not react well to light, but much better to accommodation. But again, with sectoral asymmetric sort of vermiform sort of contraction under slit lamp. So, okay, so this is where you'll see the reaction to convergence, much better on convergence, right? You can see to light, it was not easy to get him to constrict, but to convergence, so much better. Okay, so what are all these names that I'm throwing up? Many of you are very senior, so you know what these conditions are, but I'm aware that there are some junior doctors. So again, what are all these names of conditions named after strange white men? Now, of course, nowadays, there's a lot of bad things done by strange white men, but Agar-Robertson and Holmes AD are good people, so we should remember their names. So let's talk about what these conditions are. So this is a classic diagram, and I'm borrowing it from Dr. Mark Durkin. You can see that the light response basically gets out of the visual pathways and goes straight to the dorsal midbrain, where it goes across to both Edinger-Westphal nucleus through the posterior commissure and allows the light response to act through the third nerve, okay, via the ciliary ganglia. The accommodative reflex, on the other hand, comes from the visual cortex because you need to visualize before you can accommodate. So that impulse comes from the occipital lobe, goes directly anterior to the central to the cerebral aqueduct, anterior to the cerebral aqueduct, unlike the light fibers, and they go straight to the Edinger-Westphal and again through the third nerve, synapse at the ciliary ganglion, and go to the iris for the accommodative reflex. Okay, so this is how we have pupillary and accommodative response. Now, so what about these two conditions? So in Agar-Robertson and Holmes AD pupils, basically the pathology is believed to be in the ciliary ganglion. Now, the ciliary ganglion has got cell bodies, 90% of which are responsible for the accommodative convergence response. Why? Because it's a much more challenging response, requires much more manpower. Okay, so more new ganglia are required. While the light response, only about 10% of ciliary ganglia are responsible for light. So any damage that occurs in ciliary ganglion is definitely going to cause more problems with light than accommodation, simply because there's no redundancy available. Okay, so therefore, in all these conditions, Agar-Robertson as well as Holmes AD pupil, you get a classic light near dissociation where light is affected. The light is affected much more, response to light is affected much more than the accommodative convergence pupillary constriction response. Okay, but what is the difference? So classically, Agar-Robertson is small irregular pupils, Holmes AD is large irregular pupils. But the pathology in both these conditions are in the ciliary ganglion. Okay, and the pathological conditions are very similar. Okay, like syphilis, focal or systemic dysautonomic conditions, because as you know, the ciliary ganglion is an autonomic ganglion. So pathology that affects autonomic ganglia, whether it's a systemic autoimmune disease like Sjogren's syndrome, amyloidosis, or it's a focal dysautonomia like in Guillain-Barré syndrome, or the post-infectious processes that we just talked about, diphtheria, syphilis. We talked about the patient with post-viral infections in Guillain-Barré syndrome. All these conditions cause post-inflammatory damage to the ciliary ganglion and can cause any of this spectrum of changes, Holmes-Adey or Agar-Robertson. But what about inverse Agar-Robertson? So it's more difficult for you to affect accommodation preferentially than light because of the 90% predominance of the ciliary ganglion. So therefore, it is not surprising that inverse Agar-Robertson people is very rarely seen. Okay, and in the seminal post-mortem studies done by Dr. Miller-Fisher himself in patients with diphtheric neuropathy, there was segmental demyelination noted in the ciliary nerves. So for some reason or other, some of these post-infectious processes may be affecting by a disimmune process epitopes on some of these nerve fibers and therefore sparing the others. But the most common manifestation is light near dissociation, either in the form of Agar-Robertson or Holmes-Adey syndrome, Holmes-Adey pupil. And only rarely do you get the reverse Agar-Robertson pupil simply because of the 90% predominance of the accommodative fibers. Now, but what is the difference? Why two different names? Well, Holmes-Adey is a big pupil, Agar-Robertson is small. So why is one pupil big, one pupil small? Well, there are many theories behind it. Normally, when there are many theories, means we don't really know what's the cause. But one of the reasons is, as you know, Agar-Robertson is often associated with syphilis. And syphilis is a disease that affects multiple parts of the nervous system as well as the eye. So often the iris may be involved. There may be some syncytium in the iris. So the syncytium may cause some contracture. But a more favorable diagnosis, a more favorable hypothesis for the smallness of the pupil in Agar-Robertson pupil compared to Holmes-Adey is the chronicity. So as we know, denervated muscles tend to contract with time. Okay. So if you look at a child with weak legs, what happens to the tendon Achilles? It gets contracted. So the same thing happens to the iris muscle. So if it gets contracted, it's going to get small. So I think most of us believe, and I tend to support that theory, that a Holmes-Adey pupil eventually will become Agar-Robertson pupil. So from a practical point of view, whenever you see a patient either with a small irregular pupil with light near dissociation or a big irregular pupil with light near dissociation, that is Holmes-Adey or Agar-Robertson, the approach is the same. Look for syphilis, look for focal or systemic autoimmune disease, and look for post-infectious process. What about Holmes-Adey syndrome? Now, in this context, Holmes-Adey syndrome, which is kind of like described in mythological proportions in the textbook, becomes much clearer. Now, Holmes-Adey syndrome is basically women who come in, asymptomatic patients who suddenly are noted to have a Holmes-Adey pupil. And then if we check their reflexes, the reflexes are lost. Okay, and often they may have other signs of focal dysautonomia, like focal areas of hyper or hypohidrosis. So increase areas of sweating or reduce areas of sweating. Now, again, the theory is that this is a post-viral process. Now, it makes, in the context of what I've just described to you, it makes a lot of sense because I've already given you many examples of infections like syphilis, COVID, Guillain-Barré-like illnesses. These are all infectious processes that cause a disimmune process. So Holmes-Adey syndrome is probably some kind of viral infection that the person may have had in the past that cause focal dysautonomia, focal loss of reflexes, and the patient doesn't even realize, recovers from the illness, and then somehow once somebody notices the pupil and then says this is Holmes-Adey pupil, and then with the loss of reflexes and the focal dysautonomia somewhere, we call it Holmes-Adey syndrome. So in this context now, it becomes clearer what Holmes-Adey syndrome is. So in summary, whenever we see this light near dissociation, whether it's big or small, think about syphilis, think about post-infectious disorders, and focal or systemic disimmune processes. Okay, so now let's do a quick test. Or before that, is there any other reason why you could have light near dissociation? As you know, as I was alluding to earlier on, the light fibers are going in the posterior commissure in the dorsum of the midbrain, while the convergence fibers are coming from the occipital lobe to the anterior part of the adenopathic nucleus in front of the cerebral aqueduct. So there is dissociation in the real estate. So when there's dissociation of real estate, you can imagine that a focal lesion can sometimes cause light near dissociation. So therefore, not surprisingly, in dorsal midbrain syndromes like a stroke in the midbrain, Perinaut syndrome, like this man has got a stroke in the midbrain, okay, can cause the classic light near dissociation pupil, okay? So I think you can appreciate that he doesn't react well to light, but better to accommodation in this. Yes, there we are. It accommodates very nicely. And this is the MRI. It shows a lesion in the diencephalon that's extending to the dorsal midbrain. So this is a man with Perinaut syndrome. Okay, in a younger patient, you'll be thinking about pineoloma. And this man is an elderly man with a vasculopath. So therefore, he's got a stroke in the dorsal midbrain. So another classic cause of dissociation, but the pathology is far away from the ciliary ganglion. It is in the dorsal midbrain. And the reason why this happens is because of the dissociation of the fibers for convergence and light. One is in the dorsal midbrain, one is much more anterior, and therefore allows differential involvement in various pathologies. Okay? Now, let's do a test. This is Dr. Shweta's patient that I also had a good fortune to see. Let's see what's wrong with her. She's completely asymptomatic. The general practitioner sent her to Dr. Shweta for evaluation because he noticed the pupils were abnormal. So you can see left pupil is small, right pupil is big. So the first question is, what is the cause of this anisocoria? Is it physiological or is it pathological? Okay, there are many things you can sort out, but this is a simple approach that I learned from Dr. Miller himself. So basically, use a good light response and see what happens to it. Okay, is it responding well to light or is it responding poorly to light? If it's responding well to light, okay, and then of course, it dilates equally well to darkness, then we clearly know this must be physiological. But in this particular case, you can see that it's responding very poorly to light. Okay, so we have to go to this part of the equation. So clearly this is not iris sphincter damage, clearly not third nerve palsy because the rest of the eye movements are normal, there's no ptosis. Clearly there was no pharmacological blockade because this lady didn't have any eye drops and this is a chronic problem. So could this be a AIOS pupil? As I mentioned to you, AIOS pupil is classically big, but in the chronic state, it becomes smaller. So let's look at the pupil more closely. So in micro magnification, you can see that it reacts poorly to light. And then when I give an accommodative response, near response, you can see, you can almost imagine the sectoral convergence, and it becomes a bit irregular and elliptical. And more interestingly, as she removes the convergence, you can see it dilating. As I remove the near response, you will see it, okay, in a moment. Okay, now I'm going to give her the near response for her to look at. Now I'm giving her the near response to look at. You can see it will start to constrict very slowly, becomes a bit irregular, elliptical, and then when I remove it, it dilates. So this differential response told us this is a Holmes AD pupil. Her workup was unremarkable, and because of some suggestion of loss of reflexes, we presume that she's also part of the spectrum of a asymptomatic Holmes AD syndrome that I was referring to earlier, which is often due to a previous undiagnosed asymptomatic benign viral infection that came and went away. Okay, so with that now, I'm going to change gears completely now, okay, and talk about another patient that I saw with my resident a few years ago. This was back in Singapore. So the emergency doctor called us because this 50-year-old man who came in with acute vertigo and was vomiting copiously, and he also reported left eye drooping. So I went to see him, and I thought that the left eye was toast. I agreed with the patient. But my resident was a very good resident. Why was he a good resident? Because he's not a yes sir, 3 bag full sort of resident. He is, if he doesn't agree with me, he will tell me openly he doesn't agree, which is a good resident to have, right? Because then you know you are being checked all the time. So he said, doctor, no, I don't think there's any ptosis. Then I thought, how am I going to convince him? So I decided to do this. This is the inverse ptosis sign. So basically what you do is ask the patient to look up until the normal eye clears the lower eyelid. And you can see in the southern pole, there's a bit of conjunctiva seen. At that time, you'll see there's some coverage of the the lower limbus of the abnormal eye. So this tells us and convinced my resident that not only is the upper eyelid down, the lower eyelid is also up. This inverse ptosis confirm that this patient does indeed has ptosis, and most likely of the Horner's type, because that's the one that is characteristically associated with the inverse ptosis. But to be and of course, in this next video, the next morning, you can see very clearly his inverse ptosis. Okay. Now, but just to be systematic, as I was telling my resident on that day, whenever we see a single ptosis, we know there are three possible causes. It can be myasthenia, it can be third nerve, or it can be Horner's. And the differentiating feature, okay, the distinguishing differentiating feature will be the pupil. Okay, in myasthenia, pupil cannot be involved. In third nerve, it can be involved, and it must be big if it's involved, or may not be involved, but if it's involved, it must be big. And in Horner's, it must be small. So we decided to look for pupillary constriction in this patient. And indeed, he has got meiosis. Now, again, for the juniors in the audience, it's important to appreciate that when we are dealing with Asian patients and African patients whose iris are dark, you will not be able to see the resting pupil size well. So if you use a powerful torch and shine right into the iris, both pupils will constrict equally, and you will miss Horner's syndrome. Because Horner's syndrome is failure to dilate. So you need to use enough light to illuminate the iris, but not to constrict the pupil. So use tangential light like what I'm doing. Okay, just enough to do that. In fact, Dr. Miller was recently telling us that there's actually a paper which I haven't looked up, where it actually says for such patients, it's best to ask the patient look up, so that you can actually completely remove the ability of the light to constrict the pupil and shine the light from below, so that you can actually see the resting pupil size in ambient light. And you can see that the left pupil is small. So left pupil is small, so this must be Horner's syndrome. This is another example of a patient with Horner's syndrome, just to illustrate how you shine the light tangentially to illustrate the lack of dilatation of the eye. Okay. So this is Horner's syndrome. Now, once you have decided it's Horner's syndrome, what else do you know next? Now, my approach as a neurologist is slightly different. I don't really do much pharmacological testing, to be honest, because the anatomy of the sympathetic fibers is fairly straightforward. Now, what does the sympathetic fibers do? Well, they start from the hypothalamus, and they are very silent all the way down the brainstem, okay, until they come to the lateral part of the brainstem, especially the lateral medulla. Then again, they travel down the cervical cord. In the cervical cord, they become non-eloquent and very silent again, until they appear at the T1 spine. At T1 spine, they come out and become prone to pathological injury. And as they come out, as I always call the sympathetic nerves, the silly nerves of our body, because they should have gone straight from the hypothalamus to the eye. Instead, they like willy-nilly travel down the brainstem and appeared suddenly at T1 spine and realize, oh my God, I'm far away from the eye. So how am I going to get back into the brain, into the eye? So he looks around, and what does it do? Looks around and finds, oh, there's a carotid artery nearby. Why don't I just hang on to the carotid artery, and the carotid artery will bring me back to the eye? But the problem is carotid artery is so far away. So what does it do? It jumps towards the carotid artery, does a hopscotch, a somersault on the apex of the lung, and then jumps back and hangs on literally for its dear life on the outside of the carotid artery. This is an important point, on the outside of the carotid artery. And the carotid artery then subsequently brings it all the way up to the cavernous sinus and orbital apex and into the eye. So essentially, the functional anatomy of the eye, where it's prone to injury most of the time, it is in the lateral medulla, in the T1 spine, in the apex of the lung, and the carotid artery. These are the four areas that are most commonly affected. So just focus on the four areas. So let me illustrate. So coming back to this patient, we know that he's got a Horner's syndrome, right? What else? Okay, when we look at his eyes, not only does he have Horner's syndrome, but he also has nystagmus, gaze-evoked nystagmus, characteristic of a central pathology. What else does he have? He has got loss of corneal reflex on the ipsilateral side. That means his fifth nerve is affected on the ipsilateral side. And then on the same side, ipsilateral side, he's got cerebellar sign. You can see his heel shape. And in the upper limbs, he had coordination dysphagia. Okay? And not only that, very interestingly, if you can listen to his voice, he will tell you, doctor, I'm feeling numbness of my left leg, but I cannot feel temperature sensation on the other side, on the right side. So he's got dissociated temperature sensation in his limb. So putting all this together, And if you remember from our anatomy days, this is exactly in the location of the lateral medulla, where your fifth nerve, your sympathetic fibers, your contralateral spinothalamic fibers, and sometimes your 9th and 10th cranial nerve, in this case wasn't affected, but 9th and 10th cranial nerve, and your cerebellar tracts are there. So therefore, this is classic Wallenberg syndrome or lateral medullary syndrome. So with that, we asked the radiologist to point out a lesion, and indeed, there is a lesion in the lateral medulla. So this patient's Horner syndrome is due to lateral medulla. This patient also has got a very interesting sign in the eye for lateral medulla, and we call it ipsipulsion. Notice that whenever he closes his eyes, the eyes fall to the side of the lesion.
Open.
Notice that the eyeballs tend to fall to the side of the lesion. When he opens, it comes back to the center.
Close. Open.
So this is called ipsipulsion or lateropulsion. Okay. Now this is better illustrated in the next patient. This is another patient with right lateral medullary syndrome. And notice how his eyes fall to the right. You see that? It falls to the right when the eyes are closed and comes back to the center when he opens his eye. So this is ipsipulsion. There's a beautiful paper in Indian Academy of Neurology recently. So look it up if you are interested in the physiology of ipsipulsion. Now I'm almost done. So in the last few slides, I'm going to quickly go through the rest of the causes of Horner syndrome. So this woman has got Horner syndrome, clearly ptosis of the left eye with meiosis, but her clinical features are so self-evident, you don't need to do anything else. Clinical features are very clear of why she has Horner syndrome. You can see here, she's got flaccid paralysis of the left arm. So what happened is that she was involved in a road traffic accident. She's a motorcyclist. She held on to the motorcycle handle as she flew. So her arm was still stuck to the motorcycle handle. Therefore, she tore a brachial plexus. So a T1 nerve root was avulsed from her spinal cord. So this is very clear from the clinical examination. So this location is in the T1 spine. This lady came to us. She has got Horner syndrome, but that's not what she came to us for. She came to us for a wasted weak hand. So wasted weak hand in the CAT1 segment. So with that, okay, we went on to look at her eyes and found that she had Horner syndrome of the ipsilateral side. So this made us very suspicious. And true enough, if you look here, this is the, as you know, Indian women like to wear very heavy chains. So you can see that the Indian gold chain is going straight down here. But here, unfortunately, it's going up and coming down because there is a mass lesion. So she had a lesion in the apical apex of the lung that was protruding up and causing involvement of the sympathetic fibers as they were resting on the apex of the lung. So that's the cause of her lesion. And finally, this patient that I saw about a year ago in Arvind. So he's a young man from Kerala who had only 31 years old, who had a large left hemispheric stroke. And he was worked up by the neurologist, and they couldn't find a cause for his hemispheric stroke. After that, he went to the rehab center. And in the rehab center, the doctors noticed that his left eye wasn't working so well. So they sent him to Arvind. In the Arvind triage clinic, they found that he had a left relative afferent pupillary defect. And they quickly sent him to the neuro clinic. And in the neuro clinic, we noticed that he had the cause for the left relative afferent pupillary defect was a central retinal artery occlusion. So what's the connection? Left hemispheric syndrome, left CRAO. With that, we looked at him and noticed, oh, there's some suggestion of ptosis here. Okay. So, and maybe some inverse ptosis. But the people didn't look very abnormal. So if you listen to the voices here, I'm trying to tell the nurse to try to turn off the light. Wasn't so easy. But after we turned off the light, we noticed that the left pupil was smaller than the right. So in summary, he had left hemispheric syndrome, left CRAO, and left Horner's. So where is the location of the lesion? Obviously, in the only area that we haven't discussed, neck carotid artery, right? So remember, I said that the sympathetic fibers are hanging on for their dear life on the outside of the carotid artery. So any trauma to the carotid artery, especially dissection, will damage the carotid artery wall and therefore avulse the sympathetic fibers from the carotid artery wall and cause Horner syndrome. So this is another patient who my registrar was very clever to diagnose. He was a 18-year-old boy who, during national service, military service, he was doing push-ups and suddenly got neck pain and developed a hemispheric stroke, left-sided left hemispheric stroke. And she noticed that the left pupil was small with ptosis. So her diagnosis was the stroke was due to a traumatic dissection of the carotid artery. So my point I'm trying to make is that, most of the time for Horner syndrome, clinical examination will reveal one of these common sites for pathology. Okay, most of the time. So I personally feel that most of the time, just clinical examination and a focused evaluation with X-rays and associated investigation can give you the answer. Are there less common causes of Horner syndrome? Yes, indeed. So, for example, this is a slide that I took from Dr. Miller's recent presentation. You can see here, this is a beautiful picture because it tells you how the sympathetic fibers are hugging onto the outside of the carotid artery, even as they are in the cavernous sinus. And guess who's next to him? Okay, the sixth nerve. So if you get a sixth nerve palsy together with sympathetic involvement, that localization is in the cavernous sinus. So, but most of the time, cavernous sinus, the pupil is mid-size, probably because the third nerve is also involved. Okay, but if you get a Horner syndrome with a sixth nerve, location is cavernous sinus. And finally, this is another interesting case that Dr. Daniel
I think, sir, you're muted. Dr. Uma?
I think we lost your connection.
I think Dr. Uma is muted. He's muted.
Okay, I'm so sorry. For some reason, my
Yeah, it went muted, I guess.
okay, sorry. So I think the last bit
Please
I was trying to
continue.
say is that when you see a nuclear where's my slide? Okay. Can you see that? Yeah. So if you see a nuclear third, a nuclear fourth, sorry, if you see a fourth nerve and a contralateral Horner syndrome, it localizes to the midbrain. I think that part you all got. I hope so before it went off. Okay. So Dr. Ambika, can you hear me?
Yes. Now we can hear you.
Okay. So I think basically what I was trying to say, besides the four location, the two other lesser known locations are the cavernous sinus when there's ipsilateral sixth nerve. But if you get a contralateral fourth nerve, think about a midbrain because the sympathetic fibers travel next to the fourth nucleus in the midbrain. Okay. So do I ever use pharmacological testing? Yes. When I'm not sure, when the ptosis is not obvious, and I'm not sure whether it's physiological anisocoria or Horner syndrome. So this is a patient that of Dr. Sharon Tao. She kindly agreed for me to use this. So this is a man with ptosis and a borderline small pupil. As you can see, it's a bit equivocal, right? So aprochloridine was given. 0.5% aprochloridine was given. And you can see in the next video, okay, the normal pupil doesn't react very well because aprochloridine is a weak alpha agonist. So in the presence of sympathetic involvement, when there's denervation hypersensitivity, it will dilate the Horner's eye. So it has caused dilatation of the eye. So from miosis, it becomes a dilated eye. So that's very dramatic, and that confirms that this patient has Horner syndrome. So only in cases like that, when I'm not sure that I'm dealing with Horner syndrome, that I don't otherwise I don't often use pharmacological testing. One last case, which is a fun case, why the pupil helped me. So this was a patient that was just discharged to the ward for severe myasthenic crisis, who had diplopia, respiratory problems. And then the emergency department called me within a few days of her being discharged, saying that she's back again, very, very breathless, hyperventilating, tachypneic plus, and she's also complaining of severe diplopia. Please come and see her immediately. So this is what we saw. You can see in a few moments why she's got diplopia, because both eyes are converging. And what was very useful is in myasthenia, the pupil should be normal. And if there is a problem with abduction deficit, the pupil shouldn't be constricting. But for her, the pupil was constricting. So the meiotic reaction told me that this lady had a convergent spasm from hysterical hyperventilation and anxiety, not from myasthenia. So the normal pupil in this case was very useful for me and reassured me that we are not dealing with myasthenia, but with anxiety. So we gave her anxiolytics and sent her home. So in summary, I've given you a potpourri of various pupillary abnormalities. But let me just put together and give you a quick approach, a summary, okay? So whenever there's anisocoria, if both pupils are reacting normally, we are either dealing with physiological anisocoria, which means you react equally to light, and then the same amount of anisocoria exists in darkness, okay? But you can also be honest, especially if there is a ptosis associated with it. If you're not sure, the 0.5% aprochloridine can help us. If the pupils react poorly, okay, if they are big, okay, of course, it can be local trauma, which I didn't talk about at all. It could be familial palsy, almost never causes isolated pupillary abnormalities. So again, more theoretical than real. But Holmes, AD, and Aga-Robertson pupils are important to think about. And we talked about the pathophysiology mainly lying in the ciliary ganglia and how, because of the pathology, they cause light near dissociation. And in one condition, it's big. In one condition, the pupil is small. And then, of course, the same light near dissociation can occur in the dorsal midbrain only because the light fibers and the accommodating convergent fibers are diverging as they come into the adenogenovascular nucleus. With that, I would like to request that you respect the privacy of my patient's feature and not share the video indiscriminately. Thank you very much. And I can take some questions now.
Thank you so much, Dr. Uma, for this wonderful lecture on various pupillary abnormalities. I would like to ask the expert panel to come up with their comments.
Yeah, no, as always, very enthralling lecture. Thank you, Dr. Uma. So one point, just to re-emphasize what Dr. Uma mentioned, especially for juniors in the setting, that Holmes AD's pupil is not that uncommon. Please remember that you do end up seeing AD's pupil. And one of the tests that you may be asked in the exam or can be performed in the clinic is to ask the patient to read the near vision chart for a little extended period of time. Because as Dr. Uma mentioned, it's called AD's tonic pupil. What it means is that it would constrict to the accommodative target slowly. So normally when the patient looks at the near target, there'll be an immediate constriction. Versus in AD's pupil, it'll take some time before it starts constricting. And as he showed, ask him to look at a far object, it'll slowly redilate, not that immediate dilatation that you'll find when the accommodation is removed. And that's the reason why it's called tonic pupil.
Oh, that's a very nice clinical tool that I must remember. So you ask them to read. Initially, they have difficulty, and then later on, it becomes easier and easier. Oh, that's excellent.
Yes,
Yeah,
and
that's nice.
the other point, it constricts, as you said, because of denervation supersensitivity, it constricts with diluted pilocarpine. The question, of course, always is asked is that do we then use diluted pilocarpine? And as soon as the pupil constricts, their problem of photophobia and near vision goes away. The question, of course, is that why can't we use diluted pilocarpine as a therapeutic agent? Now, because of the potential theoretical side effects of pilocarpine and versus the problem that it is solving, I personally now don't use pilocarpine as a therapeutic agent, but I'm happy to hear from the others in the panel.
Okay, with the want of time, we can move on to the first case presenter, and we will have all these comments during the panel discussion. So may I request the first speaker, Dr. Luciano, to come up with this case. How mydriasis is the cause of my crisis. Over to you, Luciano.
Okay, thank you. Let's share my screen. Oh, here we go. That's okay. Is that okay? Everybody see it? Oh, I'd like to start thanking Dr. Ambika for participating in this outstanding webinar, and also Dr. Graziella Luna for sharing her case. I would like to keep the high standards of Dr. Uma lecture that he just that we had the opportunity to watch. And here we have a case of a 36-year-old woman, medical student, with a history of 1 week of acute painless intermittent episodes of blurry right vision. The durations of the episodes were about 15 seconds, with a frequency of one episode per 5 minutes. Her past medical history was relevant because of the fact that she was an ex-obese, as she underwent a bariatric surgery 4 months before the right visual complaint. However, she had a gastric fistula with the need of hospitalization for 1 month and for parenteral nutrition. She had no history of migraine. Her past ocular history was relevant to myopia, no medications, allergies, family history, and social history non-contributories. And here we have some differentiations for that visual complaint, as we know that it might come in our mind that maybe something related to the hypovitaminosis, or maybe some visual aura, or in a cephalgic migraine, or maybe an intermittent angular closure glaucoma, and also the 80s tonic pupils, and maybe something going on in a vitreous or retina or other diagnose. Then we have here in her exam some interesting findings, that she had a 20/20 visual acuities in both eyes, but with complaint on the right. But her pupils were anisochoric, and there was no RAPD. And on the right, she had a 5 to 6 millimeters width, but was difficult to measure because she had a dynamic mydrize during all the exam, and she had a 3 millimeters width on the left. Her ocular motility was full. She was orthophoric, no diplopia, and the eyelids exam revealed no ptosis. The IOP and the other exams were normal. Here we can see better her anisocoria, and as you can see on the right, she had a funny appearance of egg-shaped pupil on the right. And here we have another video that we can see the dynamic process of mydriasis on the right, and how she accommodates and make it less. And then we see that she is almost isochoric at the end of the recording, and she gets a better vision with that. Here we have some printed screens of that second video, and we see that when she has no accommodation, the anisocoria is larger, and as she accommodates, she gets better with that anisocoria and also with her blurry vision. And what is going on? Our first diagnostic impression was an episodic unilateral mydriasis that was described in the 70s by this elegant review that showed the various degrees of the duration and also the frequency of the text, and also associated to blur vision. And there are at least two forms of that episodic unilateral mydriasis. we have the non-episodic associated to the transient or permanent single episode. We can see lesions of the third nerve causing that. You had trauma, heterobulbar neuritis with dilated pupil, and also ICA occlusion. But we can see that the other form, the episodic one, associated to multiple events, that you have the third nerve palsy, maybe congenital or early acquired, due to the cyclic oculomotor paralysis. We can also find Harner's syndrome with periodic sympathetic spasms due to aberrant regeneration of the sympathetic nerve to the eye, or hypersensitivity to sympathomimetics agents, AIOS people, ophthalmoplegic migraine, and also an exposure to mydriatic drops, drugs, plants, or other anticholinergics or sympathomimetics, and also psychogenic. Here I have another example of tadpole-shaped pupils associated to the spasms of the iris dilator. And as you can see here by the drawings, during two different attacks, we have the different degrees of variation of the shape of the pupils. And this study showed 26 cases, which episodes were brief and occurred several times a day. And in 11 out of 26 cases were associated to Horner's, AIOS, and probably migraine. But the episodes eventually stopped, leaving no serious outcome. We have another term that can be used, the benign episodic mydriasis, the BEM, that was associated to anxiety after the authors ruling out other differentials to the unique mydriasis of that patient, and the patient had some difficulties with that condition. She had an exacerbation of her disease, as you can see here by these two different episodes, and they markedly decreased after the normal workup exams, making them associate this entity to the anxiety cause. And you never can forget the triad of anasocoria examination that should include not only pupils, but the eyelid and ocular motility exams. And if the larger pupil is found to be the abnormal, we must rule out the third nerve palsy. And as you can see, the present case, there was only the unique involvement of the pupil. And regarding the pathophysiologic mechanism of the BEM, we can assume that there is an imbalance between the hyperactivity of the sympathetic nervous system and the hypoactivity of the parasympathetic nervous system. And fortunately, the BEM is a harmless entity, and there is no non-irreversible damage to the eye or to the visual system. And what about the patients? The patient last follow-up showed normal neuroimaging. Luckily, she had the decreased frequency of the episodes. Now she has 5 times a day. And it's worth remembering that 1 month before, she had 1 episode per 5 minutes. And she had a vitamin intake after the first neuroophthalmic examination. And the cause of anisocoria is are variable. It starts from benign conditions to life or eyesight-threatening emergencies. We should rule out systemic causes and also the local ones. And BEM is considered a rare cause of acute anisocoria and the diagnosis of exclusion. I would like to thank once more.
Thank you, Dr. Luciano, for this wonderful case. Are there any comments from the panel?
I I would
Am I
like
audible?
if anybody in the panel had this before, because I just knew it by theory, and now
Yeah, Luciano, nice
I
case. I've never really seen one like that. But so can you remind me what was really bothering her? Was it just completely asymptomatic or did she have symptoms?
yeah, she had the blurriness. Yeah, she was
Oh,
quite
I see.
in trouble as she is in the last year of medicine and try to imagine her stage of life. And then she comes with that history of 1 week of blurriness just in the right eye. And after doing the PUPIL's exam, we found out that the problem is that, yeah. Something
Luciana,
that we uh, uh, tried to discuss is the fact that I don't know in India that if ophthalmologists usually dilate the pupils before an exam, especially in the youth, and then if you had that complaint during an exam, and then how we can find out that the problem is in the people, you know?
Dr. Mahesh, would you like to comment on that?
yeah, that's all. So usually in some instances, many instances, the technicians do dilate, but then they are trained to identify abnormal pupillary responses. And if anything is abnormal, it's always the ophthalmologist sees them before dilating. So it's not a free hand to dilate. So that's what we follow here. They're trained to identify abnormal incidents. Yeah.
Invariably, all our patients are being, during the initial workup, pupillary examination is a key before we are planning for a dilatation. So none of the patients will be dilated without the consent of the ophthalmologist who is going to see the patient. And the preliminary workups, when they are done by the optomes or by the postgraduates or fellows, pupil plays a very important role prior to dilation. So being an ophthalmic institution, I do doubt that we will encounter such problems. Yes, there may be some rare occasions, but we insist the patient to come back for a review and re-examine the pupil before we are proceeding with our clinical plan. Thank you, Dr. Luciano. Shall we move on to the next presenter?
Okay, thank you.
And we will all have a complete panel discussion at the end. And I think we are going to have the next speaker is Dr. Kumudini. She's going to present to us a case, varied lesions with pupillary dysfunction. Over to you, Dr. Kumudini.
Okay. So good evening to all. So my first case is about a 25-year-old female who was non-hypertensive, non-diabetic. She came to us with a complaint of double vision and mild headache for 1 month, and she didn't have any associated systemic disease. Her vision in the right eye, distant vision was normal, but the near vision was N36, which could be corrected with one diopter plus one diopter lens to N6. The left eye was normal. There was a right hypertropia, which was increasing in the right gaze, and the left head tilt, which was suggestive of the right inferior rectus palsy. The pupil on the right side was slightly larger than the left one and was reacting sluggishly to both the light and the near reflex. So there is a pupilomotor paralysis with accommodative paresis. And the left eye was normal in the 25-year-old female. So these are clinical photograph of the patient. You can appreciate in the first topmost one that she's a slightly right head tilt, And when she was looking on the left, there was no misalignment of the eye. While looking on the right side, the right hypertropia was increasing. Even in the first picture, the right you can see there is a more inferior sclera visible on the right side than the left eye. That is, in the primary position, there was a right hypertropia which was increasing on the right gaze. The rest of the examination was normal. She had a right inferior rectus palsy with minimal involvement of the right pupil. So that localizes the lesion towards the midbrain, because this type of clinical scenario you can get only when there is this isolated muscle involvement. You can get in the midbrain lesion with the microinfarct to one of the subnucleus or third now. And so, like rest of the, she was a young, so we got the vasculitis profile and everything. The lab investigations were normal. The MRI shows a ring enhancing lesion in the ventral part of the tegmentum of the midbrain, and that was near to the midline, and there was a perilesional edema. But the neuroradiologists were very experienced one. Like he had done a lot of work on the tuberculosis, CNS tuberculosis and neurocystic causes. He was very sure he might have done MRS, but he didn't tell us. But he was very sure this is tuberculoma of the midbrain, because other DDs, the neurocystic circus, and he said, okay, all the imaging features are very much suggestive of tuberculoma of the midbrain. So you go ahead with the ATT treatment to this patient. So when we correlate the neuroimaging of this patient with the neuroanatomy of that site, then we can appreciate that when these fibers, they come out of the subnucleus of the third now, they form the vesicles which run in the tegmentum of the midbrain. And there's a very typical arrangement of this fiber from rostral to the caudal one, and from medial to the lateral side, that the medial most are the pupillary fiber, and next to that is the inferior rectus fiber. And if we see in the neuroimaging where the lesion is also at the same location, that can explain why there is a specifically involvement of the pupil and the inferior rectus fiber, where the rest of the vesicles were spared. So okay, we gave the patient the ATT for 18 months, and clinically that double vision and pupillary asymmetry resolved completely, but she still had a mild accommodative paralysis. For that, she needed a pulse 0.5 diopter sphere. So this is a case of tuberculoma of the brainstem presenting as an isolated inferior rectus palsy with partial pupillary involvement. Now I go move on to my second patient, and that was the first patient was the parasympathetic involvement with pupil. The second one patient is the 13-year-old boy who presented with a double vision following a fall from a height of 10 to 12 feet. And when he fell down, at that time, he had a mild bleeding from the nose and the ear. That suggests he might have had a fracture of the base of the skull. The vision was normal in both the eyes, and he had a left esotropia with the restriction of abduction in the left eye, while the rest of the ocular movements are normal. He had a mild ptosis in the left eye, and with the pupillary asymmetry, the pupil in the left eye was smaller. So the ptosis with the miost pupil is suggestive, and that was anisocoria was increasing in the dark room. That suggests the patient is a Horner syndrome, along with the sixth nerve palsy. The rest of the neuroophthalmic examination was normal. So this is a case of post-traumatic left sixth nerve palsy with Horner syndrome. And as Dr. Umapati has also said that this is a very specific localizing sign, because here the only sixth nerve and the sympathetic pathway, they come very close to each other. So the patient's non-contrast CT showed a left undisplaced fracture, and this fracture line was extending to the base of the skull up to the greater wing of the sphenoid and the body of the sphenoid. The contrast MRI was normal, but the MRI of the patient with the MRI with the contrast showed there was a narrowing of the intracavernous part of the left ICA, and there was a signal alteration also. And so this occurrence of sixth nerve palsy with the ipsilateral Horner syndrome because of the sympathetic system involvement is called a Parkinson syndrome, as it is described by Dr. Parkinson first. And it's because we know this is the only structure, the cavernous sinus, where both the sixth cranial nerve and the sympathetic fiber, as Dr. Umapati said already, which are around the internal cavernous part of the internal cavity artery, they leave that uh, uh, they leave the ICA and join the 6 now for a short while, and then they leave the 6 and then run into the V1 segment, the first division of the 5th now, and then they further go into the nasociliary and enter the orbit. So this is the location. The cavernous sign is the site where both the structure are near to each other. And as we know, the sympathetic fiber, they join the 6 nerve, so they anchor the 6 nerve to the cavernous part of the ICA over here. So whenever there is a fall, there's a concussion injury over there. As you know, the the brain and the blood vessels along brain blood vessels, they are more mobile related to the fixed skull structure, and they are more for the shearing, more prone to the damage by shearing forces. And as we know, all these three structures are interconnected, the internal cavernous part of the ICA and the sympathetic trunk and the sixth. Now, all three are interconnected because of the anastomotic connection by sympathetic plexus. They are likely to be damaged over here. And the autopsy was this doctor, Sam et al. They performed the autopsy on these cases who had a severe head injury. Along with that, they had also the sixth nerve and the sympathetic dysfunction. When they did the autopsy in this patient, what they observed was that there were the hemorrhagic contusion in the lateral wall of the ICL with the hemorrhage, with the microhemorrhage and perineural edema of the sixth nerve. As we know, there's a sympathetic tethers, a sixth nerve, both the structures are damaged together. And as another patient also, the MRA also suggested that there was a narrowing of the lumen of the intercavernous part of the ICA with the alteration of the signal intensity over here there. So the patient also had some damage to the cavernous part of the lateral wall of the ICA, and these are the further they cause weakening of these weakening of the wall of the cavernous part of the ICA. So these patients had to be followed, should be followed up. So as there is a weakness of ICA, they may develop later on the post-traumatic aneurysm of this ICA. So it's very important to recognize this sign in these patients, as that points out to the particular localization of the lesion. You can ask the imaging at the particular site, and you would be very vigilant that in future these patients are more prone to develop post-traumatic aneurysm.
Thank you, Dr. Sharma. Are there any comments from the expert panel?
Thanks, madam. A very nice case. Especially the first one I enjoyed very much because he reminded us about the vascular arrangement of the third nerve, which is very characteristic, where the pupil is next to the inferior rectus and the lid and the medial rectus are far away. So nice case, madam. Thank you. Thank you. Nice.
Any kind of lid involvement in this patient, or they did not have? Sometimes it's so close to the third nerve nucleus, they can have bilateral ptosis in this kind of situation. And how, to differentiate it from cysticercosis, a singular cysticercosis there?
As such, the midbrain cysticercus in the midbrain is very, very rare. More common site, the cerebral cortex and subarachnoid spaces. And I think because of his experience, he said that it is a tuberculoma. He might have MRS. MRS study, you get the lipid peak, I think so, in case of tuberculoma.
Yeah.
And that you don't see in NCC. Or you can do ELISA for cysticercus.
Yeah, that's only question I had. Eosinophilia and other laboratory tests are there. But on the radiology, because if you give something like steroid, it's going to be really bad there. So that's the only thing I had, because both the things are prevalent in India, both in terms of tuberculosis as well as cysticercosis, because that ring enhancement, it showed exactly like that. And I was managing a case where it was exactly presenting as bilateral third nerve palsy. Pupil was probably not involved. And then it was about to be diagnosed as myasthenia, but when you got the imaging, it was cysticercosis. So we had to give the treatment. It went away after that. So in retrospect, it's very well managed case. I'm just putting a radiological difference between these two. Do we have anything? That's the only thing I had. Thank you.
Maybe I can just give one comment. Radiologically, both of them will have a ring enhancing lesion right on T2, but the cyste will definitely have a hypo-intense core with a central speck of hyperintensity, which invariably can be because of the scolex appearance. And that is something which is pathognomonic for a cyste ring lesion, unlike a, on the whole, bright hyperintense lesion on a tuberculoma. That's what is my probable comment on it. Oh, I would like to hear from my colleagues.
If I can add, we have had two cases, similar cases, right in the brainstem midbrain as shown in this case, and both were cysticercosis with a clear scolex. So it was well visible in the sagittal section. So in those two instances, we didn't have any doubts in differentiating. That was our experience.
So the central speck of bright, and
Yeah.
then a hypo-intense surrounding, and then the final peripheral rim of bright ring-like lesion, bright on T2, is pathognomonic of a cyste, unlike a tube. Yes, Dr. Sharma?
Sometimes you may not see this scolex, because in which stage the cyst is.
Agreed.
Low, like colloidal stage, and they have another one stage. So depending upon, there are 4 stages. So depending upon which stage the cyst is. Sometimes you may not see this scolex, and then it becomes, I think, MRS that at that time. He might have done so many other imaging, but he didn't tell me. But he was very sure, and he had done a lot of work, Dr. Gupta, lot of work on tuberculoma, neurocysticercosis. So he was very sure that you go ahead with ATT. I was slightly skeptical, starting ATT for 18 months, and so we should be very sure. But there was no other way to find it. And second, oh, sorry, I forgot to tell. She had the primary sterility, and she had the TO masses, tubercular ovarian masses. That goes much more in favor to she might be having a tuberculosis. So that also made us to, confirm that thinking, it's most probably likely to be a tuberculoma.
Thank you. Thank you, Dr. Sharma. And we'll move on to the next speaker. I think Dr. Mangai is already ready. She's going to talk on Horner syndrome. Over to you, Dr. Mangai.
Thank you, Dr. Ambika. I would like to thank all the organizers for this wonderful session on abnormal pupil. I really enjoyed all the talks. And it's nice to see Dr. Kumudini as well, whom I used to see at the Nanos. And there we go. Now I'll start. And Dr. Umapati's talk was excellent, and all our speakers. So that made my talk also easy. So here I present an interesting case of Horner syndrome who presented with right-sided headache and retroorbital pain. So this is a 55-year-old Caucasian male with past medical history of hyperlipidemia and pre-diabetes. And neurology was consulted for right-sided ptosis accompanied by 1 month history of constant severe right-sided headache and retroorbital pain. And during this time, he had no response to analgesics, and he was empirically treated for probable preseptal cellulitis, or even like they were suspecting maybe all his symptoms were from zoster ophthalmicus, but he did not respond to any of these treatment. He presented to the emergency room at least twice, and the initial workup included CT head, CT orbits, CT venogram, all were unremarkable. And this time when he presented, he was fortunate that to have neuro-ophthalmology attending Dr. Padmaja in the service. So he gets a detailed neuro-ophthalmology examination. The visual acuity in the right eye was 20/20, left eye was 20/25. We noticed that he had a very mild ptosis in the right eye. Left eye was normal. Extraocular movements were full. And pupil, we noticed an anisocoria. The right eye pupil was slightly smaller compared to the left eye. Then we do, like as Dr. Uma mentioned, about a detailed examination of the pupil. So in the bright light, actually, they look almost equal. But when you examine in the dim light, then you notice the dilation lag. That's very important to note here. The right eye, it was only 3 millimeter, and the left eye, 5 millimeter. You notice the difference in dim light was more. And fundus examination was normal. So here you see the picture of the patient on the top. And since we have the residents and the medical students, we wanted to do a pharmacological testing and show them. So that's why we did the aproclonidine eye drop test on him. And we can use either 0.5% or 1% eye drop. So instill like one drop on both the eyes, and you again evaluate after 30 to 45 minutes. Sometimes it may take even 60 minutes. So in the right eye, before the application of the aproclonidine eye drops, you can see mild ptosis in the right eye. And if you see the right eye pupil, like meiosis, and after the aproclonidine eye drops, there is reversal of anisocoria, and also there is, the ptosis also is resolved. The mechanism of action of aproclonidine, as Dr. Uma mentioned, it is a direct alpha receptor agonist, especially weak alpha 1. And in the normal eye, as you see, there is no effect because this takes the advantage of denervation hypersensitivity. So that's why the affected pupil responds much faster. But there are certain limitations to the aproclonidine test. Generally, it is avoided in young children because it may cause CNS depression. It gets absorbed through the blood-brain barrier, and then it can also cause acute respiratory arrest. And cocaine is a better choice for this age group, especially less than 2 years. And for the sake of the residents and the students, I've included a few other tests which we can use. Cocaine test. And the mechanism for the cocaine test is that the cocaine blocks the reuptake of norepinephrine in the synaptic nerve endings. So in the normal eye, when you use a 10% solution, you will see dilation of the pupil within 45 minutes and no effect on the Horner pupil. So for diagnosis, basically like the symptom and signs will help us like to localize where exactly, like to approximately where the lesion could be. And we heard several case presentations by our previous speakers. And also, like we know, like regarding the localization, we separate the pathway into 3 major divisions: the first order neurons, then the second order and third order. We went over the causes for central Horner syndrome. Dr. Uma so beautifully demonstrated a case of Wallenberg syndrome. Then for preganglionic, like we think about the neoplasm, that case also was presented earlier. And then postganglionic or third order neuron, we saw another case of the internal carotid artery dissection in a young male. And how do we differentiate between a postganglionic and a preganglionic or a central Horner syndrome? So we can use the hydroxyamphetamine test, but this is done only after we do a cocaine or aproclonidine test to establish the diagnosis of Horner syndrome. And usually you give a time of at least 1 to 2 days after we perform the cocaine or aproclonidine test. But generally, this is not normally used, but I just included for the sake of to know about what are the pharmacological tests that can be used. And there is no specific test to diagnose a central Horner syndrome. So how this is performed? Same way, you can place like 2 drops of hydroxyamphetamine, hydrobromide, 1% eye drops, and then you observe the pupil in the dim light after 45 minutes. So what is the response? In the normal eye, you will notice significant mydriasis because it releases the stored norepinephrine from the adrenergic nerve endings. And you see the same response also in preganglionic or central lesion. Whereas in a postganglionic Horner syndrome, the nerve endings are already destroyed. So there are no stores of norepinephrine to release, and thus there is no mydriatic effect. And the problem with this is there could be a false negative test when you do sooner, like within 1 week after the Horner syndrome. And also the commercial preparations are difficult to obtain. So as we all discussed earlier, clinical presentation is sufficient to suggest probable the site of injury, and then we can proceed on further evaluation like imaging. So in our case, since the patient presented with like headache, so we also got labs like for ESR and C-reactive protein to rule out condition like giant cell arthritis, and he was in that age group of 50 years. And imaging, MRI of the head, MRI orbits were unremarkable. And MR angiogram did not show any evidence of vascular injury. CT chest, no evidence of mass or malignancy, and MRI of the cervical spine just showed multi-level degenerative disc disease. There are reports of actually Horner syndrome that can be seen even with the degenerative disc disease. So in our case, basically, revealing when his presence of new syndrome, our diagnosis was that the Horner syndrome was from the trigeminal autonomic cephalgia. He was given valproic acid, and that significantly improved his headache, and he was discharged with valproate 500 milligrams twice. So I would like to just say a few lines about this painful postganglionic Horner syndrome. This deserves special attention because they are associated with important life-threatening causes like ICA dissection, where they can present with monocular vision loss and stroke-like complications, where, as we heard earlier, and then our case represents like a autonomic as a cause for Horner. And as we all know, in cluster headache, patients present with excruciating bouts of pain that last some 15 to 180 minutes, and they're associated with ipsilateral tearing, conjunctival hyperemia, rhinorrhea, and postganglionic Horner syndrome. Sometimes it can become permanent. And also, this is another interesting that neuralgia is called reader paratrigeminal neuralgia, where headache syndrome is characterized by persistent trigeminal pain, and they can have associated postganglionic Horner syndrome. Thank you. And thank you for all the organizers. And in this picture, you see Dr. Padmaja Sudhakar in our recent graduation. Thank you.
Thank you so much, Dr. Mangai. That was a wonderful presentation. Are there any comments from the expert panel?
A very nice case, madam. I just wondered, I would agree with everything you did. I just would have just tried, although he's an old man, I would have tried a full dose of ibuprofen, because it sounds like he may be in the hemicrania continua spectrum. So I think basically the way we look at autonomic cephalgia is that these are all groups of disorders, and there's a spectrum. One end is the episodic clusters and hemicrania, episodic hemicrania, paroxysmal episodic hemicrania, and then on the other side we have the continuous ones. And among all the various types, there's one that responds superbly to ibuprofen, so much so that you can make a diagnostic test. But the problem with ibuprofen is that you need to use very high doses, and often I I lose my nerves because, that high doses often causes kidney injury and all the other problems. So I think eventually I also tend to use things like valproate and drugs like that. So yeah, nice case, madam. Thank you.
Thank you.
Are there any other comments? Dr. Ramesh or Nitesh?
So I have one question.
Yes, sir.
So we don't get cocaine in India, and sometimes we don't get aproclonidine also. So any comments, what else can we use? Like it said that one is dilute adrenaline, or any other thoughts on that?
It's the same here in Brazil. We don't have these drops.
Yeah, very, very expensive. Even here, like the one bottle, they say it's like $700. They hide it. So basically, like I know, like clinical evaluation, but I have not used phenylephrine. But I mean, there are studies they say, but I don't think that would be reliable. I think clinical judgment would be enough. But we used it because like we want to teach the postgraduates and the students.
Thank you. Thank you.
Thank you.
Thank you.
Yeah, I
I think
agree with you,
most
Dr.
of-
Mahesh. Yeah, I too also hardly use any eye drops for partly because I'm a neurologist, so I'm biased. So I tend to go more clinical and then evaluate them. And if it so looks like an idiopathic sort of Horner syndrome, then I just keep them on my follow-up. And that case that I showed is actually Dr. Shweta and Dr. Sharon Tao's case. It was a very nice demonstration of prochloridine. So I borrowed the slides from them. So I'm on the same boat as you. I hardly use any eye drops also.
Thank you, sir.
So I just have one question. I think we all are on same page of not using that much of pharmacological testing. So if you suspect a Horner syndrome, how do you plan your workup?
So basically, I would first try to evaluate, see if there are any associated symptoms, as Dr. Uma mentioned, like any nystagmus, ataxia, to look for any central causes, and neck pain, injury. So that will point out to where exactly, and based upon that, then we can order whether the patient will need an MRI of the brain and orbits to see the cavernous sinus, or the MR angiogram, definitely, or a CT angiogram, because dissection is quite common. So, and then elderly age group, if malignancy is a concern, then a CT chest. I think based upon the age, the presentation, I would recommend imaging the patients.
I think what Ambika you mean is that isolated Horner syndrome versus other signs present.
Combined associate
When you have
symptomatology.
other signs present, obviously it becomes easier because you're going to work up that patient anyways. But if it's isolated where there are no other clinical signs on examination, but it's only Horner syndrome, I think pain is a very good indicator. I mean, reasonably good indicator. Acute onset Horner syndrome with pain, and then you ask where the pain is. If it's predominantly headache, or predominantly neck pain, or predominantly a shoulder pain. So if it's neck pain, you know that probably you're dealing with a carotid in the appropriate setting, in the setting of trauma. If it's a shoulder pain, you probably are thinking more towards, as Dr. Ma very nicely mentioned, hop across the apex of the lung to survive and climb up. So you're probably dealing with, you want to image that area, and it's headache, probably, as Dr. Mange also mentioned, probably you're dealing with readers, the paratrigeminal syndrome or stuff like that. But yeah, I mean, acute painful Horner syndrome has to be worked up. Now, what workup obviously will again be determined by the history.
Yeah, I agree. Actually, I've had a few patients, no other associated symptoms, but they were very nervous. So that's why we had to get MRI at least for the patient's satisfaction, and also to make sure that we are not missing anything. Thank you.
Thank you. Thank you so much. And I think with that note, we will move on to the next speaker, Dr. Franz Cruz. She's joining from Philippines, and she's going to talk on asymptomatic anisocoria. Over to you, Dr. Cruz.
Okay. Good evening to all the hardworking faculty on Zoom and to all our neuro-ophthalmology enthusiasts on YouTube this Saturday night. I'd like to thank the All India Ophthalmological Society and especially Dr. Ambika for the kind invitation to share tonight's webinar. I'll discuss a rather straightforward case that highlights a systematic approach to diagnosing anisocoria with a focus on clinical reasoning. Let's begin with the patient's background. Our case involves a 45-year-old female referred for a neuro-ophthalmologic evaluation due to anisocoria. She denied any eye complaints, no glare, headache, diplopia, or drooping of the eyelids. On further probing, she reported difficulty with near vision in her left eye, starting at 30 years old, earlier than expected but not alarming. Her medical history was significant for controlled hypertension and food allergy. Importantly, she had no history of ocular trauma, surgery, or eye drop use. On examination, her uncorrected visual acuity was 20/20 in each eye. Peripheral fields and color vision were normal. Her right pupil measured 2.5 millimeters and constricted briskly to 1.5 millimeters in response to light. The left pupil was 4 millimeters and non-reactive to light. Intraocular pressures as well as anterior and posterior segment exams were normal. This brings us to the diagnostic challenge of anisocoria. Traditionally, anisocoria evaluation begins by measuring pupil sizes in ambient light and darkness to determine where the difference is more pronounced. However, this can be challenging in patients with dark irises. In my training with Dr. Miller, and Dr. Uma has discussed this earlier, I learned to prioritize pupils' reactivity to light. If both pupils react equally, we consider physiologic anisocoria, Horner's pupil, or intermittent pupillary mydriasis in migraineurs. If one pupil is less reactive, we think of conditions like iris sphincter damage, cranial nerve 3 palsy, tonic pupil, pharmacologic blockade, and the parasympathetic form of intermittent pupillary mydriasis in the young that Dr. Simao discussed earlier. Beyond pupil examination, it's crucial to evaluate extraocular muscles, eyelid position, and alignment. For example, Horner syndrome presents with mild ptosis, while cranial nerve 3 palsy causes ptosis and motility deficits. Conversely, normal ocular motility and eyelid position favor diagnosis like tonic pupil or physiologic anisocoria. Returning to our patient, her ocular motility and alignment were normal, and there was no ptosis. These findings, combined with a dilated non-reactive pupil on the left, narrowed our differentials to a tonic pupil, pharmacologic blockade, or structural iris abnormalities. Among these, tonic pupil is the most common cause of an isolated dilated pupil. Clinical features include light near dissociation and slow redilation when shifting focus from near to distant objects. Let's examine the specific signs in our patient. The video on the left displays the right pupil constricting briskly in response to light. As part of the assessment for anisocoria, a slit lamp examination is performed to closely examine the iris sphincter and iris. This evaluation helps identify issues such as sphincter tears, iris senicae, tumors, iris atrophy, or transillumination defects that could impair pupil movement. In cases of tonic pupil, we specifically check for sectoral palsy and segmental vermiform movements of the iris. I was not able to appreciate these clinical features in our patient However, when we ask the patient to focus on her nose, as you can see here, the pupil constricted to 2 millimeters, demonstrating light near dissociation, a characteristic feature of a tonic pupil. Okay. This is a video of the left pupil again. Very good. The patient was then instructed to focus on a distant target, revealing a slow redilation of the pupil after sustained constriction to a near object. Notice how the pupil gradually dilates as attention is shifts to the distant object, to the distant point. Very good. Okay. To confirm the diagnosis, we use 0.1% pilocarpine, which exploits the denervation hypersensitivity of a tonic pupil. This test involves instilling the eye drops to both eyes, and a positive test is indicated by reversal of the anisocoria, similar to the Horner's pupil. After 30 minutes, the left pupil constricted significantly, reversing the anisocoria. This pharmacologic test confirmed our suspicion of tonic pupil. In summary, I presented a 45-year-old female with a dilated non-reactive pupil on the left eye. Key findings included light near dissociation, slow redilation, and hypersensitivity to diluted pilocarpine consistent with tonic pupil. But wait, one more test was done. Can you guess what it was? This is probably one of two occasions when I bring out my reflex hammer in the clinic. Neurohammer exam revealed that the patient had zero deep tendon reflexes and was assessed to have AD syndrome based on the tonic pupil and areflexia. No further diagnostic laboratory tests and neuroimaging is needed, and she was given prescription for corrective assess. AD's pupil, also called Holmes AD syndrome, named after the two neurologists that described the condition in 1931, affects the autonomic nervous system, typically presenting in young adult females. While usually idiopathic, it can result from infections, ischemia, or trauma. Understanding this condition highlights the value of a systematic approach to neuro-ophthalmologic evaluation. Management of AD's pupil focuses on symptom relief. Prescription of reading glasses or bifocals help them with near vision difficulty. And in some cases, tinted contact lenses address cosmetic concerns from anisocoria. In select cases, low concentration of pilocarpine may alleviate glare or improve near vision by inducing pupil constriction. In conclusion, a systematic approach to diagnosing anisocoria combined with appropriate management ensures patients with AD syndrome do not undergo unnecessary testing. Thank you for your attention. I'm happy to take questions.
Thank you. Thank you, Dr. Cruz. And I think most of us would come across this abnormal pupil condition in our clinic practice. And most importantly, there are a couple of good exam questions for the postgraduates if they are listening to it. What is the concentration we use in pilocarpine testing, and how do we prepare that? Dr. Cruz?
Okay, so I use a 0.1% concentration. So the formula, actually, it's a simple formula wherein we multiply the concentration with the volume equal to the concentration of the diluted with the volume. So we just have to put the bring one of the values down to the denominator, divide it. So usually I would dilute the pilocarpine with a saline solution. So I would prepare it with either a 5 cc syringe and then administer it with a 1 cc syringe.
So I think please go ahead. Please go ahead. Sorry.
No, go ahead.
Yeah, so I think the simple way to remember for PGs is that generally you get 2% pilocarpine here in India. You dilute it 16 times. and then instill the most important, I think this is often asked in the Viva, it has to be instilled in both the eyes. As Dr. Cruz mentioned, please don't say that it has to be instilled only in the eye which has ADs pupil. Has to be instilled in both the eyes so that the ADs pupil will constrict while the normal pupil will not constrict. Generally, we dilute it either with distilled water or artificial tear drops. That's much more easier on the patient's eyes.
And probably you can just check the pilocarpine percentage, what we get. If we get 1% or 2%, as she has mentioned, and we try to dilute with in a tuberculin syringe in our clinical practice. So we just take 1 cc, and then because what we need is 0.12%. So probably we take 1 cc, and then you can take it into a tuberculin syringe for 0.7 to 8, and then you can dilute it and use that over a period of half an hour. So the other question what I would like to ask my colleagues is, what is your treatment option for these patients, particularly when they come with bilateral ADs?
So I'll take it first, and then maybe we'll go to Cruz, Dr. Cruz. So that I used to use pilocarpine, diluted pilocarpine, as a therapeutic modality as well, but I've stopped doing that. The two main problems with ADs would be, one would be photophobia. They are not very comfortable in a bright light, and obviously they are not comfortable with reading. So bright light, of course, they have to use the appropriate shade glasses which can cut off the excess sunlight. And now I generally, if somebody who works on the computer or reading, and if the profession demands it, I give them a reading glasses till ADs will resolve, because a lot of these cases would resolve over a period of time. In fact, chronic ADs, the people will become smaller. So I prefer to give them the optical correction rather than the pharmacological correction. But as I said, Dr. Cruz, what would you do?
The same, actually, I would offer glasses first, and then I would also discuss the use of intermittent use of the pilocarpine depending on the situation when so they may use it intermittently on special occasions, but glasses is my first line.
Okay.
Dr.
Are
Cruz,
there
thanks so
any
much.
comments?
Yeah,
Yes,
no,
please,
just
sir.
thanks so much. I think you explained very clearly, with the very nice slides that you had about the idea that Holmes-AD syndrome is actually a form of focal dysautonomia, because basically the ciliary ganglion is an autonomic ganglia. So when it's affected, you get abnormalities in the pupil. But often these patients have, in the extended version, they can have abnormalities elsewhere. And like you said, the pathology can be many, can be a post-infectious immune process like Guillain-Barré syndrome, post-viral, or it could be immediately after known infections like syphilis, COVID, and all these things where the patient presents immediately after the infection. But the pathology is very focal, sometimes just unilateral, and that's why only some reflexes. And the reflexes are lost because the same pathology that affects the ciliary ganglion also affects the dorsal root ganglion and affects the reflex pathway without affecting the sensory nerves. That's why these patients don't complain of numbness of the hands or legs. So it's a very unusual form of this immune process, but specifically affecting one or two epitopes in the peripheral nerves and in the ganglia, and therefore they present with this. So this is the so-called Holmes-AD syndrome. So do also look out for an extended version of the Holmes-AD syndrome. We call it Roth syndrome, ROTH, where the patient also has focal sweating abnormalities associated with it. Thank you very much, madam.
Is there any clinical circumstance where you'll end up requesting neuroimaging patients of ADs people? Is there any situation where you say that you would still like to go ahead and do neuroimaging?
Not so much neuroimaging, but like what I said earlier, if the history is suggestive of a more, so you have to think about things like syphilis, HIV. If there's no clear-cut infections and if the patient develops other symptoms like sweating abnormalities, then I'll work up. As for autonomic dysfunction, so from ophthalmological point of view, it's very reasonable to send to the neurologist to work up for possible diffuse dysautonomia. I have a patient with Sjogren's syndrome who presented to the ophthalmologist with her Holmes-AD pupil. But then subsequently, when we evaluate her, She had dry eyes, dry mouth. And then she all had the signs of subtle early Sjogren syndrome. Serology was positive. And then we sent to the rheumatologist. And later on, she developed other features of Sjogren syndrome. Now, these are very rare cases. Most of the time, they are idiopathic, like the ones that Dr. Cruz did. But it's good to just keep a lookout for it. Just ask them for symptoms. Autonomic symptoms, quite easy to ask for: dry eyes, dry mouth, postural dizziness, urinary difficulties, sweating abnormalities. So if they have one of these, it's very reasonable to send to a neurologist for workup for a systemic autoimmune autonomic disorder. But imaging, I'm not so sure. I don't think the imaging by itself, because it's like a diffuse process affecting multiple ganglia, right? Unless you're thinking about a dorsal midbrain syndrome, yeah.
I think in India, before we see the patient as the AD's pupil, they will have so many MRIs visiting. With the MRIs only, they visit us, I guess, in India. That's what I have come across. You need it or not.
Bilateral AD can be presenting a symptom of Miller-Fisher syndrome. We had a young boy who had a viral sickness, and following that, a week or 2 weeks later, he came with a bilateral AD pupil. And the next day, he developed ophthalmoplegia. So we should keep that possibility also in mind in cases of bilateral AD.
Thank you. Thank you, Dr. Sharma. I think we'll move on to the next speaker. My colleague, Dr. Padma Lakshmi, she's going to talk on a case of, oh my goodness, it's an abnormal pupil palsy and a peculiar problem. Over to you, Dr. Padma.
Thank you, ma'am. At the outset, I would like to thank AIOS team and Dr. S.A. ma'am for giving me this opportunity. My case is about a 53-year-old male who came with complaints of sudden onset painless right upper lid drooping since 15 days. He had mild headache, but there was no associated vomiting, giddiness, or weakness of limbs. There was no history of recent trauma, and his medical history was unremarkable. He had consulted elsewhere and diagnosed as right third nerve palsy. MRI brain and orbit done then was reported as normal, and MRA spasm of A1 segment of left ACA and decreased flow in left MCA compared to right. Lab showed normal blood sugar levels and lipid profile. However, serum homocysteine was slightly raised. At presentation to us, examination revealed complete ptosis of right eye. Upon lifting the lid, he had right exotropia. Visual acuity was 6.7.5 in the right eye and 6.18 in the left. Pupil was mid-dilated, not reacting to light in the right eye, while the left eye pupil was normal. Right eye had elevation, depression, and adduction limitation of -4. Abduction and intorsion was intact. Left eye extraocular movements were full. Right eye was pseudophakic, while the left eye had grade 3 nucleus sclerosis. Fundus was normal in both eyes. Here is the 9-gaze photo where you can see elevation, depression, and adduction limitation, and a mid-dilated pupil. We had obtained an opinion on the MR images from our neuroradiologist, and these findings were identified. Brain parenchyma and orbit was normal. MRA showed abrupt narrowing of cavernous and supraclinoid segments of bilateral ICA. There were tiny flow signals in suprasellar cistern around basilar and posterior cerebral artery, pericollaterals. Bilateral ACA and MCA had small caliber and reduced flow. Both vertebral and basilar arteries were normal. Possibility of arthritis was given. For many years, we were taught that pupil involving third nerve palsy occurs due to surgical lesions like tumors or aneurysms, while pupil sparing occurs in medical conditions. Sometimes we do see post-traumatic or congenital cases with pupil involvement. In our case, the imaging was not suggestive of SOL, and there was no history of trauma. So we had a suspicion, could this be due to arthritis? We went ahead with relevant blood investigations, including ESR and CRP, which were normal. RA, ANA, ANCA, dsDNA were negative. A temporal artery Doppler was also done, which showed normal flow pattern without halo sign. Even clinically, the patient did not report systemic symptoms of GCA. This patient with normal inflammatory markers, given the MRI finding of occlusion, narrowing of major blood vessel. Now, what's the next step? Whether to do a DSA or a biopsy, or what treatment to suggest? We went ahead with the DSA first, and these were the findings. The first image shows reduction in the caliber of a right ICA from proximal cervical segment. The second image shows occlusion of a right ICA just distal to the origin of ophthalmic artery and dural collaterals from ophthalmic artery. The third image shows dural pile collaterals from right external carotid artery branches. Here there is complete occlusion of the left internal carotid artery after the origin of ophthalmic artery. Generalized reduction in caliber of the left internal carotid artery. In this image, the right PCA is grossly enlarged in caliber and supplying pile collaterals to right MCA territory, and occlusion of left PCA with a small puff of smoke appearance. This image shows robust posterior communicating artery supplying anterior circulation in bilateral cerebral hemispheres. The DSA also showed beaded appearance of right superficial temporal artery. The pattern according to DSA was that of Moyamoya disease, but suggested that the etiopathogenesis could be due to cranial type of GCA, as there was a beaded appearance. Now we thought that the third nerve palsy could be due to cranial arthritis. Patient underwent temporal artery biopsy and received 3 days of IVMP followed by oral steroids. At around this time, patient had to leave station. He was advised to consult with the interventional neurologist locally and review after 3 weeks. By then, the TAB results were out. To our surprise, the H&E slides showed that there was no inflammation in the intima. There were multiple foci of calcification seen in the tunica media and the muscle layers of the artery, and there was no multinucleated giant cells. An impression of Monckeberg's medial calcific sclerosis of temporal artery was given. Monckeberg's medial calcific sclerosis has been reported in literature in the context of headache and facial pain and even in NOIOing, but couldn't find in relation to nerve palsy. There are reports which say that it can mimic GCA. Here there is calcification of tunica media and or internal elastic lamina in small and medium-sized arteries. The exact pathogenesis is unknown, but it is more common with advancing age, type 2 diabetes mellitus, and chronic renal dysfunction. The disease primarily affects the arteries of extremities and visceral organs, but temporal artery involvement is rare. Pupillary dysfunction in our case could probably be due to the non-aneurysmal arterial compression by the robust PCOM. Our patient, a middle-aged male with acute pupil involving third nerve palsy, biopsy negative for inflammatory changes GCA, with a histopathological diagnosis of Monckeberg medial calcific sclerosis of temporal artery, and radiologically showing bilateral ICA occlusion, a Moyamoya disease without brain infarcts. What could be the possible etiology in this patient? What further investigations are required, and how do we manage? Request expert panelists and faculties to give their inputs and comments. Thank you.
Thanks, Padma. Very nice case. Can I just ask you something about the headache? Is it recurrent thunderclap-like headaches?
No, sir. He complained of dull aching only, mild headache.
Oh. Because, you know, a lot of times when we see patients that look like pure CNS vasculitis, what we used to think as pure CNS vasculitis, a lot of them have turned out to be this condition called reversible cerebral vasospasm syndrome, where the patients present with recurrent thunderclap-like headaches associated with vasospasm. Etiology is difficult to sort out, but a lot of times it is related to drugs that the patient may be taking or misusing, including amphetamines, or sometimes it's just idiopathic and it occurs in patients for no reason. But I've not seen patients developing cranial nerve palsy. I've seen them developing ischemic insults to the brain itself, but this I've not seen it with nerve injury. The other thing is that you saw some Moyamoya-like changes, so therefore we can put under the broad spectrum of Moyamoya syndrome. And then once it's Moyamoya syndrome, then we start looking for things like antiphospholipid syndrome and other forms of disorders that resemble childhood onset or young onset Moyamoya disease. So I think in terms of workup, that's what I would suggest, that I would at least add syphilis, antiphospholipid antibody, lupus anticoagulant, as well as then for treatment wise, I would suggest that we manage the vasospasm with a drug like nimodipine, so that we can try to dilate the vessels. And again, most of the time we use the headache as a marker when we use nimodipine. So in this case, it's not going to be easy. I'm not sure how the headache is doing now, but these are my suggestions. But please keep us posted. Thank you.
Thank you, sir.
Thank you. I think this patient was not that bothered with headache. And when we started evaluating the cause for the pupil involving right third nerve, and we were not able to figure out any vascular abnormalities which are described in the textbook so far. So then we were surprised to see that extensive, all the arteries involvement and the beaded appearance on the DSA. In fact, our interventional person, she called, and so she said that, I don't know, at a look of it, there were so many beads on those arteries, and that's something abnormal. So we were all banking that he's going to come back TAP positive, and we ensured that he had a long segment to be biopsied, but he turned out to be negative for TAP, and he's around in the early 50s, and no signs of any temporal arthritis. But our pathologist was very, very clear, and then he said that, no, this is histopathology is not for a temporal arthritis, but surprisingly, it is like a monkeypox. But he doesn't have any other venous infarcts or any other neurological features to add more evidence for arthritis. But the Moya Moya picture, again, there is a robust arterial collaterals close to the PCOM. So is this the PCOM collaterals or the arterioles which are booming out over there, which is pressing somewhere the pupillary fibers in the free subarachnoid space, is our hypothesis for the explanation for the pupil involving right nerve. So we thought that we will bring this case to this, webinar where pupil is being targeted upon. I would like to hear from my colleagues too.
There's one other point that I would like to mention. So if there are a lot of this moya-moya-like vessels, then sometimes they have small amounts of bleeding. So if you look under the GRE sequence for siderosis, superficial siderosis can sometimes cause cranial nerve palsies, but typically they cause the 8th cranial nerve with hearing loss and the 6th cranial nerve. I've never seen one with third nerve. So, but it's useful to just look at the GRE sequences to see whether there's a lot of hemosiderin deposition. Over.
And that eye where the pupil was dilated was a pseudophakic eye, right? So did you see some local factor which would have just caused the dilatation? Because that
it doesn't look like right, what you pointed, but it didn't look like a pseudophakic aneuploidy.
No, just a short. I said because we are not able to explain this dilatation.
Exactly.
We have got, that's why
exactly. And we're not able to explain the histopath with the MRI feature and with the third nerve, and we are just waiting for him to come back because we have just put him on steroids, and the interventional radiologist and the neurologist have also called the patient for follow-up. So probably we'll get more to know about subsequently, I guess.
And ESR is only 6. So that...
Yep. Yes, all the markers are negative.
Well, Dr. Ambika, was there any response to the steroids? I don't know whether I got
We are waiting to see him.
See the response, okay.
Yep.
Yeah.
So we just finished the biopsy, the IV, and then he's on oral now. Hopefully we will see him by 3 to 4 weeks, I guess.
We remember seeing some similar patients with pupil involvement in idiopathic pachymeningitis. And so, of course, it's a clear-cut inflammation and with the pupil involvement. And here, as you say, pupil involvement is unexplained. And how do we explain that? We don't know.
I just had one doubt. Is Moya Moya anytime having an involvement of pupil involving cranial nerve palsies?
No.
Not that I could see anything in the literature. Dr. Uma?
No.
Yeah, I don't remember, but I did not. But if you did do a search, then That'll be more accurate because I mean, off the top of the head, I don't know. But I'll be hesitant to call this moya moya. I'll just use the term moya moya syndrome because it could be secondary to. And also, there's absolutely no chance that he's using one of the drugs that cause vasospasm. I understand in North India, I've blocked on the name. There's a substance that they use, they chew on it, and what is it called? It causes quite a bit of vasospasm, something that they chew. I forget the name of the taxi drivers and all that to keep awake. Rasmin, do you know? I'm blocking on it. Yeah. I thought it's quite a well-known substance that's overused.
Is it a substance or a drug you mean?
Yeah, it's mildly it's addictive. I'm blocking on the name.
Ergot? Is it?
It's sorry again. What is it, madam?
Is it ergot? Ergot that they do chew.
Ergot. Yeah, it's something that's used for chew. It's a stimulant, keeps them awake. The drivers often use it. Yeah, I'll look it up. But again, it'll be good to ask him whether he's taking any amphetamine-like drugs, amphetamine-like drugs that causes vasospasm.
We will. Sure.
Ambika, is it possible that you said the people was involved in this patient, and though it is a vasa nervorum which are supposed to be involved in the vascular, is it like pupillary fibers are supplied by pile blood vessels of the neighboring artery, whatever they are in the course of third now, and the rest of the somatic fibers are supplied by vasa nervosum. So is it possible those the PCOM and other they had so much of occlusions like I see it? Is it possible that pile fibers, pile arteries are supplying to the pupillary fiber are also involved?
Yes, you're right. So it could also be possible because the amount of narrowing of these arteries and smaller arterioles, it's quite significant. And I don't know from how long he's having this disease entirety, and only the third nerve palsy evaluation has opened up to this so much of MRI findings for him. And MRI also was minimal, but once we moved for a DSA, we picked multiple vascular territories being involved, which is what we were, not able to put it on the etiological, cause behind this entire disease. Dr. Luciana, do you have any comments?
Oh, I was just wondering regarding the TBA that you just did perfectly, because otherwise we won't know, because we were having some kind of discussions between you do the ultrasound of the temporal artery and versus the TBA, and that's a discussion that there's no end. And then you just did very well. And I don't know if another trial of a second look of the biopsy, maybe you may have that opinion of the pathologist to do it just once more to make sure that it's not the missing something. Yeah, the temporal arteries.
Agreed.
Dr.
Any other comments, please? Yes,
Dr. Kumide, did you mention Gudka? Is it? I looked it up. I think it's called Gudka. Gudkaa. It's a form of.
What is?
Is that what you mentioned?
No, I said I didn't mention the gutka. Gutka, I don't know what it contains, but they take gutka. Yeah. That's right. But what gutka contains, nobody knows. You know, yeah.
So I remember in North, one of the two places I worked, they have told me about how the people use, especially the taxi drivers and auto riders.
To remain awake, yeah. Yeah, I was saying that ergot causes vasospasm. I don't know gutka contains anything which causes vasospasm. That I don't.
That can also have areca powder. Areca powder has a dilating effect on the pupil. So that's one of the things. Arecanut has that effect on the pupil, so they can be dilated. There are some studies also somebody has done with the pan and gutka. With both, they have done it. So it causes dilatation of the pupil.
Yeah, I'm always suspicious of 50-year-old men.
Mm.
Doing things that are.
But our man is having a unilateral anisocoria.
Yeah.
He's got a
No.
with a third
No,
nerve
but
feature.
third nerve, yeah. So, men are always after funny things, so don't trust them.
So, okay, so the workup, what you have advised is to plan for nimotopin if the headache is persistent, and maybe get more on workup on infective causes. Check for
Yeah,
the use of any
syphilis,
of these drugs.
syphilis, antiphospholipid antibodies. These are the things I tend to do whenever I see Moya-Moya-like syndrome.
Okay, are there any other comments? Thank you. Thank you so much for all the speakers for sticking to time and giving such wonderful presentations. Thank you, expert panel and the chairpersons for joining. And in special thanks to Dr. Uma, Dr. Cruz, who are way beyond their routine time. Thank you for joining, and hope to see you all soon way back in India. Bye.
Okay, good night.
Thank you.
Good night.